keep discussion to the end of the session. Thank you so much. So next speaker will be introduced by Professor Amina Sultan.
Thanks, Dr. Suba. And now with Dr. Rasha Khan, lecturer of radiology at Sura University, and Mimickers of lung cancer.
Good morning. I'm glad to be here today to talk about mimickers of lung cancer. So first, these are some cases that I'm going to present later in this session. For these lesions, lung cancer, they may mimic lung cancer. But I'm here to tell you that not every lung mass is a lung cancer. In the last decade, the high-resolution CT chest and multi-detector CT made it possible to show the morphologic characteristic of pulmonary lesions, so help in accurate diagnosis of lung cancer. However, some lesions still mimic lung cancer, even with the current CT techniques. Lung cancer can present as peripheral pulmonary nodular mass, like in cases of squamous cell carcinoma, central pulmonary nodular mass, like cases of small cell lung cancers, areas of consolidation or ground-glass opacities like bronchoalveolar carcinomas, or cavitary lesions like cavitating squamous cell carcinomas. So, regarding peripherally located lung cancers, some lesions may mimic these cancers, like benign tumors, pulmonary EVM infections such as fungal infections, and hereditary. As you see in the chest X-ray, there is a well-defined left parahilar mass. However, on the CT chest, this lesion appears well circumscribed with foci focal calcifications and areas of density. This lesion was a hamartoma, which is a benign lung tumor characterized by fat within the lesions and foci of calcification, which is usually focal. And the key differentiating point here is the fat content. Here is another case with history of fever and cough, and as you see here in this CT chest, there is multiple lesions. Some of them are irregular with even speculated margins seen scattered in both lungs. However, this patient had prior CT 3 days before, and these lesions were much smaller. After adequate treatment, after 2 weeks, these lesions nearly disappeared. So this was a case of fungal infection or pulmonary cryptococcosis, which characterized by single or multiple pulmonary nodules, areas of consolidation, and some of nodules may cavitate in cases of immune compromise. And the key differentiating point here is the clinical picture and the follow-up. Here is another case of left lower lung pulmonary nodule, which may mimic lung cancer. However, if you look closely, you can see that there is a feeding artery and draining vein coming into and out of the lesion. And this lesion was a pulmonary EVM, which is a rare vascular anomaly characterized by nodule or serpiginous mass with or without villi and show feeding artery and draining vein. And this is the key differentiating point. Another lesion which may mimic lung cancer, as you see here, this is a lens-like lesion based on a thickened pleura with radiating veins come out and from it. And this lesion was round atelectasis, which present as pleural-based mass abutting a thickened pleural surface with committal sign, which are bronchi vessel coming in and from this mass. So the key differentiating point in differentiating peripheral pulmonary nodule from peripheral lung cancer. First, the prostate, as Dr. Suba said, the prostate is the most valuable information as stability of pulmonary nodule for over 2 years is highly associated with benignity. Second, when you see an incidentally found pulmonary nodule, it should be followed up according to National Society guidelines. Third, fat within a pulmonary nodule which is stable for a long time is pathognomonic for hamartoma. Second form, lung cancer can present as central lung mass, which should be differentiated from other hilar masses such as carcinoid tumor, progressive mass fibrosis, and other hilar masses. As you see in the chest X-ray, there is bilateral speculated parahilar masses. On the CT, there are multiple perilymphatic nodules with prediction to the upper and middle lung lobes, and there is associated peribronchoscopal thickening with radiating bands coming out lymph fluid. And on the mediastinal window, there are foci calcification within these lesions and calcified mediastinal lymph nodes. And this was a case of progressive massive fibrosis in a patient with psychosis, which presented as mass-like lesion with radiating bands, foci calcification, and shrinks over time to migrate towards hilum. The key differentiating point here is the associated signs of pneumoconiosis, like perilymphatic nodules, lymph nodes with foci calcifications, and pleural thickening, and of course patient history. Another lesion here, as you see, well circumscribed lesion seen in the bronchial within the right main bronchus. The lesion is homogeneously enhancing and associated with atrectic changes and epizontis changes. And this lesion was pathologically proven to be carcinoid tumor, which is a neuroendocrine tumor characterized by hormone secretion. 50% of patients may present with hemoptysis, however, 25% of patients may be asymptomatic, so discovered accidentally. And the key differentiating point is the homogeneous enhancement and the endobronchial location, and it may show foci calcification. Another bilateral parahilar masses here on chest X-ray, and on the non-contrast CT, they appear well circumscribed, as you see here. However, on the post-contrast study, they appeared as aneurysms with partial peripheral thrombosis. And this case was a case of Behçet disease, which is a multi-system vasculitis, affects lung in 1 to 8% of cases, and characterized by bilateral multiple pulmonary nodules. So it's mandatory to perform post-contrast study in any case with parahilar masses. Third is a consolidated form of lung cancer, which may mimic other causes of chronic unilateral alveolar obesities like pneumonia and lymphoma. As you see in this case, there is an area of consolidation surrounded by areas of ground glass obesities with airborne program inside. And this is a typical case of pneumonia, which may present as local segmental or subsegmental area of consolidation, is bearing large airways, and may be associated with areas of ground glass obesity. And the main key differentiating point of pneumonia from other causes from lung cancer is the presence of acute pneumonic symptoms and the good response of treatment, and usually simple pneumonia is not associated with enlarged mediastinal lymph nodes. So the key differentiating point of consolidated form of lung cancer from other mimickers: first, the presence of pneumonia in a patient with high risk confined to one lobe, not responding to treatment for 2-3 weeks, is usually concerning for lung cancer. Second, if pneumonia occurs secondary to underlying neoplasm, it never resolves completely. Third, simple pneumonia is usually not associated with enlarged mediastinal lymph nodes. The last form of lung cancer is the capillary form, which should be differentiated from other causes of capillary lesions, such as pulmonary TB, lung abscess, and Asperger lung. As you see in this case, there is a left upper lobe capillary lesion with a smooth inner margin surrounding areas of consolidations and associated central lobular nodules and 3 umbilical nodules in the left upper lobe. And this lesion was post-primary pulmonary TB, which has prediction to the upper lobes and is usually associated with consolidations and like to cavities. Another lesion here which may mimic lung cancer is lung abscess. As you see in this lesion, is capillary lesion with a smooth inner margin with air fluid level inside, and this is typical lung abscess, which may contain fluid alone or air fluid level, typically surrounded by areas of consolidation. However, after adequate treatment, the consolidation resolves and the cavity is the only one which will present. So the main differentiating point is the smooth inner margin of the lesion. So the key differentiating point of capillary lung cancer from other causes of capillary lesions: first, in capillary squamous cell carcinoma, the border of tumor are often irregular with nodular inner surface. Second, is the discordance between the inner and outer walls of capillary lesion is usually associated with lung cancer. Third, in active pulmonary TB, there is usually areas of 3 umbilical nodules and areas of consolidation associated with the lesion. These are my references. Thank you.
بسم الله الرحمن الرحيم والصلاة والسلام على رسول الله. برحب بكم جميعا، برحب بأساتذتنا بالمنصة الكريمة. أتقدم بالشكر للأستاذة الدكتورة مها بلال على الدعوة الكريمة لقسم الأمراض الصدرية. Now we will invite again Dr. Soba Ikumarsi for a title lung cancer stage.
Thank you very much. I really enjoyed it.